So this is a peripheral smear, and I will say this is our case 1 because different peripheral smears we'll be studying over a period of time, and we'll try to decipher how it goes. Like, without knowing the diagnosis, we'll go forward, so that we try to learn to identify them. And in clinical practice, nobody tells you what it's gonna be. You are the one who's responsible, so to diagnose it and give the clinician a clue whether you are thinking about thalassemia, or is it iron deficiency anemia, or megaloblastic anemia. So the peripheral smear picture is very important. So I have decided to segregate this, and right now we'll only study RBC morphology. We won't be studying anything about WBCs or platelets. We'll go one by one. So this is case 1, and we'll be focusing on RBC morphology. Okay. So for RBC morphology, I would say look for 3 things. First is size, then is shape, and then abnormal cells. Just about this slide, when you put it under 40x, this will be visible. Maybe this is 10x, not 40x. Okay, so 10 or 40, both. All right. So what do you see? First you will see the size. Start with the size. Imagine there's this small lymphocyte. Okay, and now you have to see whether the RBC is equal to, lesser, or more in size than the small lymphocyte. So always compare to small lymphocyte. Okay, small lymphocyte. Now if it is less in size than the lymphocyte, automatically it becomes microcytic. ठीक? Okay, now when it is microcytic, now chances are that it will be hypochromic also. Now how will you deduce hypochronia? You will see the pallor inside the cell. Like a normal RBC would be this. Okay, just the central pallor. All right, but as hemoglobin reduces pallor, the white space inside RBC increases. So it can go like up to if anemia is severe, it will be like more than like 1/3. It will be more than 1/3. But in this, pallor is there, but not that much. Yeah, it's not covering more than maybe 1/3 of it, right? But still we can say that this is hypochromic. As you can see, chrome. What is chrome, by the way? It's color. What is cytic, by the way? It's a cell. Okay, micro means small, as you all know. Microscope, micro, so microbiology, anything micro is small. And hypo means something less. If it is more, then will be hyper. So for example, there's this RBC which is filled with this kind of color, and there is no central pallor, then it will be hyperchromic. But mostly hyperchromic is used for malignant cells while we are describing the nucleus. So we are mostly tackling hypochromia in hematology peripheral smears. All right. Now, so as through size we have decided that this is microcytic hypochromic with in the comparison of small lymphocyte, and also color of the pallor inside the RBC. Now next is shape. Now you have to see whether the shape is. So what is the normal shape? Normal shape is biconcave, and in 2D you will see oval. All right. So this oval, this is normal, but as anemia progresses or hemoglobin becomes less, cells assume different morphology. So it can be anything. All right. So in this, as you can see, these are teardrops. Okay, as if tears are coming out of the eyes. So these teardrops you have to mention. So teardrops cells are observed predominantly. This is how you will report it. Okay, predominantly. as you can see teardrop. Now as soon as you see teardrop cells, look for target cells. What are target cells? Target cells will look like this. So there will be hemoglobin here, pallor area, and then another rim of hemoglobin like a cell. So it's like a bullseye. All right. So cells will be arranged like this. Size will be okay like this, but there will be a central dot of hemoglobin, then pallor, and then hemoglobin. Okay, yeah, here like this, central red color, and then this, and this whole red color will be white. I'll explain it in the next slide maybe. So in this, at least in this peripheral smear, only teardrops are present and shape size is microcytic hypochromic. Now shape, as you can see, there are teardrops and there is a variation in size. Not every RBC looks alike, so obviously there is difference in shape as well. So you can say that there is moderate degree of anisopoikilocytosis. Anisopoikilocytosis. Okay. Moderate degree of anisopoikilocytosis. What is aniso? Difference in the size, variation of size. And poikilo is variation in shape. Variation in shape. So I can see different variation in size and I can see variation in shape. So I'll say moderate degree of anisopoikilocytosis. And in abnormal cells, I only see teardrop cells. I cannot see anything immature. RBCs are mature with the central pallor. So this is what is the diagnosis here. It will be microcytic hypochromic picture with predominant teardrop cells. Okay, teardrop morphology. When you say teardrop morphology, automatically physician or clinician or hematologist will think about thalassemia and further investigations will be carried out. But as a pathologist, your part is to suggest. So how will you suggest? You will suggest fetal hemoglobin levels, HPLC, to exclude thalassemia, because teardrop cells are predominant, so maybe target cells will be there. And so and PS you have already done. Serum iron will be done, serum ferritin will be done. Okay, serum iron will be increased in case of thalassemia, ferritin will be increased in case of thalassemia, bone marrow iron will be increased in case of thalassemia, and HbA2 levels will be increased in case of thalassemia. So after all these tests, one person, a clinician, will make a diagnosis of thalassemia. But before that, if you do not have any information around anything, then this is just microcytic hypochromic picture with teardrop cell morphology. That's it. This is how you report it. All right. So this is case 1. Further investigations will tell you whether it is thalassemia or iron deficiency anemia, but till here just microcytic hypochromic anemia. Okay, let's find out what do you see. Just forget that you know the diagnosis or whether what are the other blood tests which you can correlate. Just look at the picture and what do you see. Let's start with this picture. As you can see that there is this one small lymphocyte, so that's your clue. Clue is that some cells are smaller than the lymphocytes. So 50% are equal to that lymphocyte and 50% are smaller. So we can safely say that there is a microcytic picture which is developing. Okay. Now, as you can see, the inner white area which is called as pallor or is more. So it is a moderate to severe hypochromia. Okay. Now what is the second picture? I can see one pencil cell and one teardrop cell. So definitely there is variation in size and shape. So I will say anisopoikilocytosis is there. Okay. Aniso means variation in size and poikilo means variation in shape. Now, if you have mentioned that there is anisopoikilocytosis, you definitely mention what are the abnormal cells you see. So, I see there is a pencil cell, then there is a teardrop cell. Pencil cell, and there is a teardrop cell. In this picture, I see one target cell. So, third abnormal cell I see is target cell. But I do not see any RBC with a nucleated pattern. So I will report that there are no nucleated RBC, because if there are nucleated RBCs, that will suggest hemolytic anemia. And here, because there is anemia, find nucleated RBCs. If there are any, report them, because that will be a very important and a strong clue that hemolytic anemia can be the etiology. So nucleated RBCs will suggest hemolytic anemia. So in this case there is no hemolytic component in play. So it's a we're pretty sure that we can report it as microcytic hypochromic. And then in suggestions, instead of HPLC, because there are no nucleated RBCs, we can suggest that there are serum iron studies, serum ferritin studies, and transferrin saturation studies. And what else about, because of target cell you can, yes, write HPLC for thalassemia, but I am pretty sure that it will be thalassemia negative in this case. So yeah, whenever we see a particular peripheral smear, we should not jump to the conclusions. We should just look for the features first. What are we seeing? For example, you just note what you are seeing instead of what is the diagnosis, because diagnosis will be made later. Also, there is a differential diagnosis for every case possible. There is no definitive diagnosis. Even if the picture is classical, then also you have to give a benefit of doubt and some ancillary studies so that it can be proved. All right, so in this picture particularly, what do you see? For example, I see that there is hypochromia, because I can see a lot of white which is there. Okay, so this hypochromia is moderate to severe for according to me. Yeah, then I see small cells in comparison to small mature lymphocyte, which is not visible in this screen, on this screen. But due as we grow and see thousands of cases, we know that this is microcytosis, even if there is no mature lymphocyte to look or compare with. So I see microcytosis. Yeah, so definitely this is microcytic hypochromic. Suddenly my mind will start thinking around iron deficiency anemia and thalassemia. Now I will start looking for target cells. I cannot find any target cell, because if there was a target cell it would look like this. So there is no target cell, but I see lot of fragmentation in RBCs, like damaged membrane thing. Yeah, it's like a damaged membrane thing. But how will I differentiate between a schistocyte, which is a fragmented RBC, how will I differentiate a fragmented RBC of iron deficiency anemia and microangiopathic will be caused in case of prosthetic heart valves, where RBC pass through certain structure, causing damage to the RBC structure or morphology. So they appear as this. But the main difference is, in iron deficiency anemia, these fragmented RBC, they maintain a central pallor. So as you can see, there is a central white space which you can see, which confirms that this is an iron deficiency anemia picture. And in severe cases, schistocytes are present. But if this was a case of microangiopathic hemolytic anemia, then it would lack the central pallor. It will be all red, no central pallor in between. And what other cells I can see? There is no teardrop. Yeah, there is a bit of teardrop here. And yeah, there's pencil cell I can see. So these are the structures I see. And then again, serum iron studies. I will suggest, serum ferritin I will suggest. And this is how we approach a case when we see a one peripheral smear. Do not jump on diagnosis, I am again saying, because that's not necessary. What is the finding? What are the findings you are jotting down? That's what is important, because once you jot down everything you see under the microscope, your diagnosis will be screaming. If you know, you know, something like that will happen. So just take care of the size and the shape and the abnormal cells, and diagnosis is not far. Yeah. How do you decide whether the RBC is normocytic, like of a normal size, microcytic, like a smaller size than it should be of, and a macrocytic, like a bigger size than the normal? So the clue is always the mature small lymphocyte. So the reference of comparison is mature small lymphocyte, like here. Now if you see, this is the size. So RBC is just a little smaller than the small lymphocyte. But if the size is significantly smaller or larger than the small lymphocyte, then you term those RBCs accordingly. Like if, for example, this RBC is way smaller than the small lymphocyte, so we can clearly, confidently say that this picture is microcytic. But if a cell is larger than it, like where do I maybe this screen does not have a macro, but like this, yeah, oval and macro, so that would be macrocyte. So that will be macrocytic picture. Sometimes you get both, like there is a mature lymphocyte and you can see micro as well as macro, then you call that picture dimorphic picture. What is a morph is a morphology, shape of it, shape and size. Okay. So dimorphic means, di means dual, so two type of morphology you can see. So one is microcytic and another is macrocytic, and that's why you call that dimorphic anemia. Dimorphic anemia can be present in iron deficiency anemia, which will cause the microcytic picture, and vitamin B12 and folic acid deficiency, which will be causing the macrocytic picture. So this is how you decide. So just look around for a nice picture of mature lymphocyte in that field, and then start comparing the surrounding RBCs to confirm it as normocytic, microcytic and macrocytic. So when we see a variation in shape in RBCs in a single slide, like under one focus, then we call it a poikilocytosis. This P and this P. Do not get confused with variation in size, which is called as anisocytosis. Alright. So these are the most common shapes you will find, and if you find them, you have to report them. First is elliptocyte. So the name suggests the shape. It's very easy if you really just mug it up once and then try to Google it, try to see it practically if it is possible. Otherwise, just keep on doing the atlas thing of hematology and you'll be, mugged up. Elliptocyte. Normally, RBCs are like this, and now you can see that it's like a ellipto thing. So this elongated elliptocyte. Elongated. E stands for elongated, E stands for elliptocyte. Now a spherocyte, as it suggests, it's a sphere. So RBCs are also almost this shape. What is the difference? Spherocyte does not have a central pallor. That means everything is red. This cell is completely red, full of hemoglobin, and the where the pallor is supposed to be, like where nucleus should be absent, there is hemoglobin in it, and that's why it's a condition which is called as hereditary spherocytosis. Now, stomatocyte. What is a stomata? Stomata is like an opening. Must be you must have heard it in plants. Stomata. under the leaves. Yeah. So what is a stomata? It's an opening. Now what is the difference between this and normal RBC? In normal RBC, central pallor. Pallor is central, but in this, it's like a slit. The pallor is like a slit, so it is a stomatocyte. All right. Now schistocyte. Schistocyte is like something which was traumatized. The shape is distorted because it was traumatized. Just imagine there's this pipe with lot of spikes, and there's this something very soft like RBCs passing through that pipe. Okay. Now these, what will happen to those red blood cells? They will be mutilated. Their shape will be mutilated. There will be a lot of destruction of RBCs which will happen. Correct? So this fragmentation, destruction, mutilation of RBCs, this shape, what we get is schistocytes. So anything which is improper shape, you cannot categorize them into anything which we have discussed already, then you can say that, safely say that this is a schistocyte. Okay. Now teardrop cell, it's a medical term, dacrocyte, but we usually write teardrop cells, proper teardrops. Okay. Like if a kid cry, you see teardrops, exact that shape. And when you say see a teardrop cell, just think of thalassemia, just think of iron deficiency anemia. It's pretty common. Yeah. Now a sickle cell. Sickle cell, like a tool in the farming we use to cut the grass. It's like this, sickle, to cut the grass. Okay. So sickle cell, exactly that shape. And we have a term sickle cell anemia for it. Okay. One important part about sickle cell anemia, it provides a little protection against malaria. So this is something which you should know for your exams. Okay. Now Burr cell. What is a Burr cell? It's called as echinocyte. So Burr cell shape is like a floozy. It's a little floozy. So remember blur. Blurred outline is Burr cell. You will not remember Burr, but you will always remember blurred. So when the outline is blurred, like blob, fluffy, then it's a Burr cell. Okay. Again, a spur cell. Now it is called as acanthocyte, but S for spikes. Okay. And S for spur. So if you remember spur, if you remember spikes, and the combination of spur and spike is called as acanthocyte. Okay. And again there is a target cell. Target cell, very common in iron deficiency anemia and thalassemia. It's very important. If you see those, report it. It might help the physician to get the diagnosis right. And what is the target cell? It's like a bullseye, that dart game you play when you were a kid. So there's hemoglobin patch, then there is white pallor, no hemoglobin, and again there is a hemoglobin zone. So it's like an alternate pallor hemoglobin zone. So this is called as target cell. So these are the variations in the shape which you find in day-to-day practice of your clinical hematology. If you are a pathologist, you're trying to report. So this is how it goes. These are two different patterns in which RBCs, they stick to each other. So here you can see that they are stacked like coins, like one coin on another, like we used to play games in our childhood. Yeah. So this is a very specific pattern, stacking coin like pattern. Okay. And this pattern itself, where you can see as if there is a line of coins settled together making a big long tail, and also there is hypochromia, there's little less color, then it's a roulette formation. You need to remember this spelling. Okay, because I always used to get really confused, still I am. So this is a roulette formation, and it is typical of multiple myeloma. Of course, you need to find other things like plasma cells and other cells. So this is a rouleau formation. Now there is another pattern of RBCs in which they kind of stick together, but these are like clumps. So these clumps, you can see, they are indefinite, no shape clumps. It's like haphazard. So this is an agglutination reaction. As you can see in the picture itself, Rowley formation is very specific, like coins are neatly stacked. But in agglutination reaction, there is this irregular clump of RBCs put together. So this agglutination reaction is caused in incompatible blood transfusion. So blood transfusion reactions, if somebody gets a wrong blood group, like for example some patient is A positive and he receives B positive or any other blood group, then this will be the peripheral smear of that patient. So agglutination reaction is suggestive of incompatible blood transfusion, and Rouleau formation is suggestive of multiple myeloma or infection. So if you see Rouleau formation, report it. But if you are asked whether the patient was having incompatible blood transfusion, look for agglutination. Sides, we have talked about different shapes, different sizes, but now let's talk about what if the RBC size is greater than small mature lymphocyte. So this peculiar size is most commonly found in vitamin B12, folic acid, intrinsic factor, pernicious anemia, and vitamin B12 and folic acid deficiency. Okay. Now, what are these called? Uh, these big cells are called as macroovelocyte. All right. Now these macroovelocytes, along with hypochromia, I can see that there's a lot of white color inside. So there's hypochromia as well. So macrocytic, hypochromic. Now there is a teardrop cell as well. So we report teardrop cell. Now what are Howell Jolly bodies? Inside the RBCs only, we see dot blue color. These are blue in nature. Here, here, yeah. So these blue dots are actually, what are these? Nuclear remnants. Nuclear remnants, and they stain blue. So these blue color, they are actually Howell Jolly bodies, very peculiar in megaloblastic anemia, which can be because of vitamin B12 and folic acid deficiency, or sometimes because of intrinsic factor deficiency, or if a picture is just limited to the peripheral smear and it is not affecting bone marrow, then it can be because of alcohol and other factors also, like drugs, or sometimes it can be because of hepatic disorders. Okay. Now what is basophilic stippling? Basophilic stippling is that you have one RBC and there is all blue dot all over it, like this. Yeah. So these blue dots covering the cytoplasm. So this basophilic stippling is pretty common. Then you see nucleated RBCs. Now we'll take nucleated RBCs in the next slide. But yes, nucleated RBCs are also seen. And what are nucleated RBCs? They are still retaining the nucleus and present in peripheral smear, which is not common, because if it is there, nucleated RBCs are there, then definitely you should look for hemolysis, you should look for nutritional deficiencies, and you should start looking for other features suggestive of hemolysis, intravascular, extravascular, whatever. And then retic count is also to be suggested. If you see nucleated RBC, just suggest reticulocyte count as well. And one very peculiar neutrophilic change in vitamin B12 or folic acid deficiency will be hypersegmentation of neutrophils. Yeah. What is hypersegmentation? Hypersegmentation is that instead of 3 to 4 lobes in neutrophil, more than 5 lobes are present. In this picture, you can see 1, 2, 3, 4, 5, 6, 7. 7 lobes are present. But what is the amount of hypersegmented neutrophils which should be present to call it that hypersegmentation of neutrophils are present? For example, there is just one. Can you say that this is hypersegmentation of neutrophil? No. It should be more than 5% to say that this is hypersegmentation of neutrophils are present, and then you start looking for megaloblastic elements here and there. Okay, so just a small revision: macrovelocytes, teardrop cells, oval jolly bodies, basophilic stippling, nucleated RBCs, and hypersegmented neutrophils. This peripheral smear, you see that there are two type of cells. Yeah, first are the red cells, like these. Okay, so I do not see any central pallor, so can be spherocytes. All right, but I see like a something which was there but now it's not there, like this, like this. So medically we call these cells as ghost RBCs. Sometimes it's just an staining artifact, so do not assume that if this is present, intravascular hemolysis is actually happening. Sometimes it's just the artifact, just an artifact. And if it's not an artifact, like you go for another stain slide, and then also if it is present on a very fresh, like on fresh clean slide, good stain slide, then if it is not an artifact, then it can be intravascular hemolysis, and it can be because of bacterial infection, it can be because of low levels of phosphorus, and sometimes drugs like propofol. So consider everything before giving it as intravascular hemolysis. So when you see ghost RBCs, just write these in your suggestions. What can you write? You cannot write an artifact because your lab stained it. So it is not right that you write, oh, maybe it's an artifact. No, it's actually stupid if you think like that. So write about intravascular hemolysis. Okay, then bacterial infections correlate with TLC. If there is a bacterial infection, then TLC must be increased. There must be something in neutrophils or anything, something CRP, TLC, CRP, ESR, something will be there which will correlate with bacterial infection. For lower phosphorus levels, you can always go for serum phosphorus. Okay, now for drugs, you can take the history from the patient. History is very important in this, and if these causes are excluded, then you can go for intravascular hemolysis test. That's it. That's how you suggest, and you report ghost RBCs seen. Now, where you can observe in this slide, there are normal RBCs, and also one very peculiar formation of one shape which is round to oval. So this is an oval, again oval. This is also an oval, oval, and oval. Yeah. So these oval shaped RBCs are called as elliptocytes. Now, significance is when patient is having some liver disease, or there is a condition which is called as myelofibrosis. In both the cases, in suggestions, if you see that there are a fair amount of elliptocytes, you can definitely go for LFT and gamma GGT. And if clinician is suspecting anything like myelofibrosis, then definitely person will suggest bone marrow studies. So in both cases, you can suggest these, and then you can write as a correlation like LFT and gamma GGT to rule out liver etiology, and bone marrow studies to rule out myelofibrosis. So this is how, if elliptocytes are seen. What you see is an echinocyte. In the previous slide, we discussed how spicules can change the name of the RBC we are dealing with. So the other one, previous one, was acanthocyte with irregularly placed spicules. Now in this, as you can see, these are pretty much placed nicely. Spicules are uniformly placed with equidistance. So this is an echinocyte. It will suggest maybe cell dehydration, electrolyte abnormalities, drugs, and renal disease. But as a pathologist, as a lab person, as a lab technician, as anybody who is dealing with peripheral smear, you have to report it as echinocyte. And if they are in fair amount, just say that echinocytes present in fair amount, and then in suggestions write electrolyte, serum electrolytes, and exclude drug history. And then maybe you can suggest KFT and other things to rule out renal diseases, or with electrolyte imbalance you can rule out cell dehydration. So all of that. So echinocytes are equally important, and they give a clue towards dehydration or something related to kidney. The typical cells which we can find and we have to report, because it can lead to a diagnosis. It can help a physician to get to a diagnosis if there is something he or she is suspecting. So as we have discussed earlier also under the section of poikilocytosis, like the abnormal shape of RBCs, that but in this particular slide, what do you see? You see a normal RBC, and also you see a little Burr cells, okay, and you see acanthocytes. Now what are acanthocytes? RBC can have two type of spikes. Spikes means spicules, like thorns, okay. हिंदी में इसे कहते हैं कांटा. All right. Now, if it is irregularly spaced, then it is an acanthocyte. But if it is regularly spaced, then it is something else. So you have to see that whether it is regularly spaced or irregularly spaced. Now in this you can see that they have no particular space which you can say that okay, this is uniform. So here and there, wherever they want, they are coming out as a projection. So these are acanthocytes, where spicules are irregularly placed, and you have to write it because it can be due to fragmentation injury, or maybe increased cholesterol in the membrane, like in DIC, or glomerulonephritis, like if there is something wrong with the kidney. So maybe this will happen. And severe form of iron deficiency, this can happen. In GI disorders, it can happen. So if you see acanthocytes with irregularly placed spicules, spikes, or thorns, just report them. So this is a drying effect artifact. It's very important because sometimes it is reported as parasite. It's not a parasite. It do not confuse it with parasites, because and also you can correlate with eosinophils. So if there is no eosinophilia and you still find this, restain with the fresh slide, and then see, because sometimes it is about the contaminated stain. Staining reagent is bad, so you change the sample. The fresh stain should be used, and then make the slide, then stain the slide. Because this moth eating, as if some insect is trying to eat, okay, it can look like a parasite, but somehow you will know that these vacuoles, these air something, air vacuoles, something is not inside the RBC, and it is just above it, like a superimposed thing. So you do not confuse it with a parasite. It is not a parasite. It is actually contaminated stain which is causing this. So these vacuoles will be like moth eating insect something appearance, and then this is actually a drying artifact. Do not confuse with a parasite. And it's very important, because clinically when you are running a lab, or when you are sitting in a lab, you should know what to do about it. So if you see this, you have to ask your staff or a helping colleague or anybody whom you're dealing with, that please change the batch of the stain we are using. Sometimes it is just about the stain and nothing to do with the patient.